So I just thought we'd talk about transfers. We're just going to start off with some general stuff. I think people get involved in like the care, the bedside care, and everything like that, and that's just your day to day, right? And it's like, oh, we'll just transfer them out, or the doc can be like, you know, I'm sure you've seen it too. Like you're in Edmonton, somebody's on 9 infusions and CRT, and they're like, yeah, we need a head CT, and you're like, how long does that take? That probably takes 3 or 4 hours just to fart around and get somebody down to CT and get it done. Like it's hard in hospital. So it's harder out of hospital. I've moved ECMO patients, I've moved, you know, people on balloon pumps and stuff like that. And it's not a simple process, right?
Yeah.
But it's said so easily and it's arranged so easily sometimes. But the actual doing it is super complicated, and so many people are involved in making it happen. And we can talk a little bit about, you know, you've probably been exposed to PTN and how all that's supposed to work and whatnot. It's a little complicated, but I've sort of seen it from both sides, and we'll talk a little bit more about another role that we have that kind of helps and sort of maybe give everyone some insight into how the transfers just come together. That's just a picture of our boat. WCGH has a couple of contracted boats. This one's down in Sydney to service the Southern Gulf Islands, and there's another one in Chemainus. And they're great because they're actually made, like the stretchers, just the door opens, the stretcher wheels in, locks in, there's oxygen, it's inside, it's heated, like just all these things that are really tricky, because sometimes we end up on just shitty little boats, like manually hauling stretchers over beaches, which is just gonna hurt people, you know, and so these are really nice, and they're trying to get one of these. There's been talk about trying to do this in Tofino because of housing is such a big deal. You know, there's so many people there, and there's a call right now going on and it's a bit of a gong show, like in terms of trying to provide care in Tofino. So I don't know, hopefully we'll see more of these, and for Nanaimo as well, because Protection Island, Mudge, Newcastle, Gabe, like there's all these places that need help, which when the ferries aren't running, you know, like you still need to go at 2 in the morning. So, you know, we have a couple other resources that we use on our side. We have a pretty big fixed wing fleet in BC now that does most of the transfers, and we have brand new planes pretty much still coming online in a new contract, which is great because they're pretty capable. They're all like this. They're technically King Air 360s if you're a plane geek, but they during the contract they wanted to go to something called a PC-12, which is a single engine plane with the same engines that you see on these. It just has one of them on the nose. That's what they use in Orange and stuff in Ontario. And everybody here is like, no, I'm not getting in a plane with only one engine. It's not happening. So like with all the flying we do, it gets pretty spicy around BC, right? Like with all the mountains and stuff. And the helicopters, that's actually a picture I took here, which is kind of cool, I thought. But we just got new helicopters that have just come online with a new contractor, and they're pretty sweet. So it's really actually improved a lot of our ability for flights and weather and stuff like that. And they're all fancy and safe, and 2 pilot, 2 engine, which is a lot different than the States where they just like to crash air ambulances all the time. They compete for insurance money. So these are pretty good. They're pretty safe, night vision, like all that kind of stuff. But they still have their limitations, right? They can't fly if it's icy or snowy or freezing rain. Helicopters don't fly in that. So like that's a lot of the time. It also comes up a lot here where you go outside and you're like, looks fine, you know, and everybody starts like chirping on the phone like they know what they're talking about, and you're like, yeah, but you're sitting in Parksville and it's just totally fogged in. You know, it can be way different just in that short distance. So sometimes things like that are like, you know, the weather's down, and you're like, what do you mean the weather's down? But if you can't, even across the strait, sometimes if a crew has to come from Vancouver, it's just like, no, we can't get across the strait, it's super foggy or freezing rain or whatever, and if you start to ice up your rotors, then, you know, you crash. So that's bad. So I thought what we might do is maybe just walk through what we have in BC for qualifications for crews, because it's a lot different, and you've probably had sort of tangential interactions with ambulance crews, but to get to know kind of what they are, will be kind of helpful, especially when we get into the stuff later about actually doing a transfer. And like, I think everybody's main worry in doing a transfer is when shit goes wrong. If you just get in the back and talk to Andy about her, whatever, you know what I mean? Like, and take her down to Vic, it's like, okay, that's fine, like whatever, that's simple. But I think the big concern for most people, and I'm not a nurse, so you guys will have to tell me if I'm off base. My wife's an ICU nurse in Nanaimo, so I just rely a lot on what she says too. But it's I think people worry about that. Yeah, but what if something goes wrong and it starts to get spicy? That's the big concern, during transfer, right? But let's talk about sort of who might be there with you, because we're just going to do an overview of the various license levels in BCHS, and then just kind of come to understand the capabilities of the crews. And I won't bullshit you, we'll talk about the realities of what's going on in BCHS, because we have a huge juniority problem with a lot of people coming out too, right? Obviously I was feeling clicky with transitions or something at that point. So in BC, this is hilarious. We actually have something called a driver only. They have a new name now, but it's basically a driver only. And their only job is to drive the ambulance. They don't do anything. They're not medically trained at all. This is really meant for Zabalis or places that are so small where they do 80 calls a year kind of thing, and they just can't staff it. So it's just some nice dude from town who's yeah, I'll just come drive the ambulance, and that's kind of what it's meant for. But what that's transitioned into, as we need more and more people, is they'll just hire people. And now if you get hired as a driver only, there's an expectation that you'll achieve the EMR, the next level, within 6 months and be licensed and start doing it. But they're out there. They're not really around the Central Island too much. So there's been a couple hired, but there's also been a bit of pushback from crews and everything saying no, this is not appropriate. You need a partner. You can't have somebody who can't help you. But it's a reality. So all they have to have is a CPR level C. They're not responsible for any patient care, but they go through what's called our new employer orientation, or NEO. And that's something when you get hired into BCHS, you go to Vancouver for 2 weeks and they put you up at a shitty hotel, and then you go in, and it's all of just learning the structure of BCHS, how our stupid tough book PCRs work, patient care records work, how to use the stretcher, how to use the chair cot thing to get people out of houses, just how to use a radio, things like that. They do a driving course to go on the track and rip around in an ambulance and hit cones and stuff. And so that's the new employer orientation that everybody does. And that's kind of all they get. And then they're sent to a station to just drive the ambulance around, right? And they don't really talk about anything else. So, I feel like you just take people, you're hey, drive an ambulance. You get to drive on the track. You're this is super fun. Then you go back to Zabalis, and your first call will be a dead 4-year-old or something. Who knows, right? We don't do a good job of preparing people for the realities of that sometimes. So they're just a pair of hands is all they really are. So the next thing that comes up, that's an actual licensed is what's called the EMR, Emergency Medical Responder. And I put these pictures up because we used to have, it's kind of becoming less popular, but there used to be these little color tags that were in, and that was sort of denoted everyone's qualification level. We've kind of transitioned to epaulets like this, so most people will have them. Some of them just say paramedic, which isn't super helpful. I don't know why they have those. But for the most part, they'll say EMR, or they'll have the qualifications on there. So that's just a quick thing you can do to glance at when people come in. You can kind of see hey, what level of training does this person have? And it'll give you a quick insight. I'm so far away from this thing. So it's literally 3 weeks of training. So these are the drivers, and they go and they do 3 weeks of training, right? It is not much. And in that 3 weeks of training, what they end up doing is just focusing on a primary and secondary survey, right? They're taught a patient assessment model, check for hazards, go in, check for deadly bleeding, or, consider C-spine when you walk in, ABCs, do a rapid body survey, make a decision about whether you need to, what you need to do in a ABC capacity, or, do you have time to go into a history and vital signs and all the rest of it. Obviously they learn, CPR and AED use. They just do spinal care, collars and that sort of stuff. Basic airway interventions EMRs have, so OPAs, nasopharyngeal airways, and learn to BVM. And then these are sort of the drugs that they're exposed to at their level that they can give. So obviously Narcan, they can give epinephrine now for anaphylaxis, which kind of makes sense, I think, especially because more and more communities are being served by people it's just EMRs. If you go to Denman, you might just have 2 EMRs on the crew. So, if you're in anaphylactic shock there, it's well, I'd rather have somebody half-assing it who might give me epi than somebody who won't, So, all right, that's cool. They can give oral glucose as well as nasal glucagon now. We have nasal glucagon on all the cars. They can do IV maintenance, which means basically they can watch something drip if it's saline, so it's not all that helpful. I don't really know why that ever comes into play. They can give salbutamol by NEB or by MDI, and nitrous oxide for pain. They can also give Tylenol, which is just PO Tylenol. I'll use some acronyms and abbreviations and stuff, so just stop me if I'm just like, how it is, word speak, I'll try to limit that. So EMRs, I think there's around 1,000 in the province right now, out of all the paramedics. So on the island, probably well over 100. I think we have roughly 800 paramedics on the island or something like that. So probably over 100 of them, 150 are probably EMRs at this point. New people coming in, because they also get EMR, get hired, start accruing seniority. It makes sense if you're advising anyone to do it. It's like, well, don't go to school for 2 years to become a whatever. Like, go and get hired, and you might as well accrue seniority while you work on your license, on your higher license level. So it kind of makes sense. Also, people from smaller towns, Swantula or whatever, you can get people in the town to do 3 weeks of training. You can't get people in town to go and do a year or two. If they want to help out their town, kind of thing. It's just not realistic. And then this is my favorite one. Is they probably get like a 1-hour lecture on childbirth, which I just think would be hilarious. And I want to see that happen. It's not going to go well. So that's the EMR level. The next level, and these should be pretty common, like across the country too. Like these are getting pretty standardized. But the primary care paramedic, or PCP, is that's the base. That's what BCHS wants, is like the base level of training in all over the place. That's what most people are here in town, and then IMO everywhere else. Most crews are PCP crews. So the schooling here is just shifted now to just over a year long. It was about 6 months. It's just shifted to a year long. There's more prerequisites. They're trying to bolster it and move towards sort of the more diploma type of program for the you do get a diploma, but I don't know, qualifications here are a bit weird. But they are moving. There's a recognition that they need to sort of front end more just general knowledge, like A&P, pharmacology, like take some courses ahead of time before you go out and start doing stuff. So yeah, it's about a 1-year program that just started, I think, like this year. It's shifted to a 1-year program. EMR is a prerequisite to get into it. And then there is a diploma. So if you do a few more courses plus your PCP, you do get a 2-year diploma, and then you can actually leverage that into like the TRU degree. They have a Bachelor in Health Sciences that you can do and stuff, and this forms some of that. What does a PCP do? Well, they can do obviously what an EMR can do. They also initiate IVs, so they have just D10 and saline on car for treating diabetics and then hypovolemia. For meds, they have additional indications for epinephrine. They can give it in severe bronchospasm just to provide a bit more beta-2 love. They can give tranexamic acid for trauma. Ibuprofen, they give Toradol IM or IV now, as well as ipratropium along with the salbutamol, Gravol, IV acetaminophen, and then there's a few that I haven't put in here, but dexamethasone for croup or COPD, which has been a little bit weird. I think somebody advocated to put it in a treatment guideline for us, but it's, who needs dexamethasone in their house before they go to the hospital? But for kids with croup and longer transport times, it's reasonable. And they have hydrocortisone too for Addisonian crisis, which is hilarious because like nobody has that. But it's, but I honestly, the story I heard is that like somebody knew somebody or has pictures of somebody from like some politician-y type person's family member has Addison's disease, and next thing you know, we all have hydrocortisone on cars. So obviously that's how shit really gets done. So they have more options available to them to treat a lot of sort of common ailments. Supraglottic devices, so maybe you've seen the eye gels in place when they come in, to places, as well as anyone, have you guys seen them come in with the CPAP? Mm-hmm. No? Maybe I've got one in my car, maybe I'll bring one in and I'll show you guys the CPAP, because it's actually something that, it's not like being on a vent, in the Emerge or something, but they're pretty effective. when it comes to dealing with things that are amenable to CPAP. Like mostly I tell people like pulmonary edema, maybe COPD. Those are the bang for the buck for CPAP. So it's pretty handy. Morphine keeps getting talked about whether that's going to come on car, but I think there's a lot of, that's like 200 stations and like 3,000 paramedics. You need to give access to morphine all around the province in small towns, and it's just, I think people worry about that. There's also a trend away from opioids in pre-hospital because there's been a lot of correlation. We actually have a PharmD that works for WCHS now, and she's awesome, but she does a lot of work and says there's a direct proven correlation between the administration of pre-hospital opioids and people being discharged on opioids. And you can, like, the more, if you're there, you're so many more times likely to be discharged on opioids. Just because I give some morphine in the field, we come in, it's like, yeah, morphine worked. You're like, hey, can we give some morphine? And the doc's like, yeah, sure. And then they go to the ward with a narcotic prescription and they get discharged. It just sort of, just has its own sort of momentum a little bit. So there's a bit of a trend away. That's why they brought Toradol on car for paramedics. They've also talked about ketamine for pain for PCPs. But I think you can get adverse events with ketamine, and I don't know that that's something we want to set people up for in the field. And it's one thing to think about it in the context of giving it like in town or right around here, but imagine a misdosed somebody going wiggity whack on ketamine, like an hour away from anything, in the back of an ambulance with nothing. I don't know. It seems bad.
Grandma's in the back tripping.
Totally tripping.
It's not the place where KO experience.
Yeah. I find dosing is, you guys seen dosing go weird with ketamine? Mm-hmm. Yeah, right? It's not awesome. I feel like, what's going on? So we'll see. I think the pain management is always a big question. We used to have those inhaled, the Penthrox. You might have seen those green whistle things come in, but we got rid of those. Ostensibly because there was some OSH health, I think somebody was like, I don't know, because you can only use it so many times a day because of off gases in the ambulance or whatever. But the real answer is they were $60 each, and so they stopped it. It's just because we were going through so many of them. It was costing us hundreds of thousands of dollars a year. So I think it was just a money thing. Morphine's cheap, so maybe we'll see that happen. The next level is the advanced care paramedic. So and I should update this slide because I say they're only found in larger centers and on Vancouver Island. There's 3 units in Victoria, which there is, and 1 unit in Nanaimo. But now there's actually what we call a PAPA car, which is just Alpha, Bravo, Charlie, Delta. It's just in the phonetic alphabet. So PAPA is the designation for a single responder ALS person. And as part of the response to the ICU closing here, there was a big scramble, and last week they put on a PAPA car in Port Alberni 24/7. So they put an ALS resource here, which there never has been before. There's been talk about it because I think it's warranted just from a pre-hospital stance to have an advanced provider around to be able to do stuff. But it came about, I think, if the opportunity presents itself politically, I think you jump on it and you make it a thing, and then it's too hard to get rid of. Mm-hmm. I think that seems to be how healthcare works, right?
That's what I was going to say. Do you think that could potentially be something that ends up staying here, even if our ICU does open back up?
I don't see how you get rid of it once you have it here, honestly. I think it establishes itself because, when's the ICU opening again? I'm sure if the news comes in and asks, it's very temporary, very temporary. You're like, is it though?
And even once it opens again, when's it going to close again?
Yeah.
Because we've had this is obviously indefinitely right now, but we've had multiple. So
yeah, and the ICU here, it taps out at a certain point, right? Pretty quick in terms of services, what's available, subspecialty care, that sort of stuff.
Very basic.
Yeah, a lot of things end up just going to Nanaimo or Vic, right? Yeah. So, and this role here. ACPs have always traditionally been a pre-hospital resource. I worked as an ACP in Surrey before I went and did the critical care stuff for 5 or 6 years, and you were just pre-hospital ripping around doing calls all the time, right? That's your job. And it's only been in the last couple of years that there's been, with hospital closures and all this stuff, and there's a lot of politics around it, but there's been a big push to say ACP trained people need to start doing transfers, right? Because these are the ones that have cardiac monitoring, they have that stuff. Well, let's go through it and we talk a bit more about it. But you have about 18 to 24 months of training, depending how you're precepting. And once you finish your schooling, you come in and you do an ACP orientation with us, which takes about 3 or 4 months, where people just get more mentoring in the field and evaluations before they're, told they can go and kill people on their own. So they get a lot of additional training in like cardiac respiratory trauma assessments. You get a lot more preceptorship, which is huge, right? To actually go and do the job with somebody. And then you do, like I say, this ACP orientation at the end of it. So the ACP practice includes a lot of things like intubation, and there's a lot that goes into training that, but their tools aren't perfect the way we do it here. A lot of talk about it all the time about whether ACPs should have RSI and paralytics on the street or whether they shouldn't, and there's kind of, I don't know, it has gone back and forth. It's an old debate, so it keeps coming and going. But they do have all their ACLS, they do lots of training, and not just ACLS. We do this for like 2 years of training. Like you're out there doing bradycardic patients, tachykardioverting them, running arrests, a lot of arrests. But so you end up doing pacing and cardioversion. They have access to benzos and opioids, they have ketamine, they have phenylephrine, push dose epi. They'll probably be getting Levophed soon as well on the street, because in the last year we've introduced IV pumps to ACP practice as well, because before it was always eyeballed or just, like push dose stuff. And we finally got pumps to say, hey, if you're giving somebody ketamine post-intubation for a half-hour drive, we'll just put them on infusion. Or, or if you're running epi, instead of guessing how many trips you're running, like this is insane, right? So, you actually need to put people on a real infusion if you're giving it for bradycardia or whatever. So it's easier to introduce new drugs now that we have pumps, because it's just, obviously that's the standard. They can do surgical airways, like what we call front of neck access. So, we train people to do that very simply, just with you make a cut, and then you stick a bougie in it, and then you shove a tube over it. It's a very simple process, like in terms of the training. And then a bit of advanced diagnostic training, like you get a lot more into 12-lead interpretation. They just get better at lung sounds, like sort of general assessments. So in BC, which is kind of unique in Canada for the most part, is it's a very targeted response here. So it's not like in a lot of places, like they might have a lot of ACPs, or you're an ACP truck, you're a PCP truck, or whatever, and they just kind of do the calls. Here, ACPs are targeted to specific calls based on how we triage them in the 911 queue. And so we'll send them to the chest pains, the status seizures, the traumas, that sort of thing. But the ACP crew won't be sent to routine calls, unless a crew gets there and says, hey, we could use ACP, they can call for them, of course, and they'll come and help. It's nice because it keeps ACPs seeing higher acuity patients, so you get better at it. Generally don't do transfers, but the star is there because obviously in the last even 6 months there's been a big transition into saying we need this to happen. Port Alberni now having this PAPA unit, as I called it, this single response ALS person, is not unique in the province. There's one in Campbell River actually, there's one in Salmon Arm, there's one in Williams Lake, Penticton. There's a few places that have these now, and part of their role is to do transfers. Now there is CERT and there's heart in the interior and stuff like that, but the idea, it's so complex, right? Like part of it is a little bit of unionism comes in, because our union goes, hey, doing out of hospital work is our job, and heart terms and CERT, heart teams and CERT teams are there because BCHS never did its job in terms of providing the right care during transfers, right? And allowing nurses and docs and stuff to stay in hospital, doing that. So, they've developed their teams, which kind of makes sense. I think it's just natural. But I think there is a bit of a sense of, and pushback from the health authorities saying, like, we don't have nurses everywhere, and we always just say, can you send a nurse? Can you send a nurse? Can you send a nurse? Is a common thing. And a lot of places here, this is honestly a bigger center in the province, right? You start asking Tofino to send a nurse all the time. Well, that transfer is going to take 6 or 8 hours, and who knows what's going to happen. Like, it's a long way in the middle of nowhere. So the transfer thing is changing a lot, and that's part of why we see this ACP resource here too, is it will be tasked with appropriate transfers.
So when we send patients out IVs and ambulance now, they're all ACPs?
No, they're all PCPs.
PCPs.
They're all
okay.
PCPs,
Okay.
yeah. So one of the biggest differences is PCPs don't have monitors, I say with the star, because some PCP cars do have monitors, but the PCPs have never actually really been trained to use them. And it just drives me crazy to no end how we did this. But there was some push and some money at some point, so somebody bought some monitors and threw them on a car. I gave them a 6-hour course and said, okay, you put these stickies on, and And then the hospital goes, well, they need to be on a monitor. We go, yeah, we got those. And then we put the stickies on and send them with a PCP crew who doesn't have ACLS, doesn't have any drugs, can't really interpret the ECG. And you're like, well, what the fuck? Like, that doesn't make any sense, right? Like, if you need to be monitored, I presume it's for a reason. Like, you need to be shocked or cardioverted or paced or something might go wrong, right? It's not just for funsies. There's actually a process in place on the island now where we're doing a trial. All these, because we do a lot of transfers where people are moved out just on telemetry, right? Like, they just need to be on the monitor. And now our big question is why? Why? What's been going wrong on those transfers? And CERT does a lot of those where they just go up and move people on monitor. Like, they're not doing anything. They're just putting them on a monitor and taking them to Victoria and bringing them back. And you know what goes wrong? Nothing. So the big question is like, well, do they really need to be on a monitor? So there's actually a thing going on right now where there's certain criteria, but these patients, even if they were thrombolized last night, if they've been if they're relatively hemodynamically stable, they'll say take them off the monitor, put them in, because if we just do that, well, we can move them right now and get them to Victoria. If we have to wait for a monitor or CERT or a nurse to become available, now transfer is going to be delayed by hours or until tomorrow or something. So it can get a little, there's always risk, but it's about sort of managing that. It gets a little technical, but our entire practice is actually in legislation. Like, there's regulations from the government that define what paramedics can do at different levels. So we're not tied to orders in any sense. It's our license, right? So if I want to pace somebody or put them on levo or say, we need a second line vasopressor or something like that, I don't really need to ask anybody. Well, at my level, I don't. So there's some freedom in that, which is kind of nice. Like, I sort of alluded to things like, can you even get a hold of the MRP? I mean, you guys at least have a doc that's paid, I assume, handsomely to answer the phone. But if you're just sending a nurse from somewhere, if they can't get a hold of the MRP, they're kind of screwed, right? If things change and they need to talk to them, right? So, but there's a clause in this licensing that says that ACPs can give medications that are out of scope for them, so things they don't have available, things they can't give. They can give those medications if they consult with our doctor, with our medical control. So even though, like, levo isn't in their scope, if they're in the hospital and they're asked to do a transfer, because maybe somebody's just a bit sick or kind of like, just baby septic and they're just like kind of going to an IMO or whatever, it's like the ACP can do that transfer because they have a pump now and they can go in and they can just throw them on the monitor, do it, make a phone call, say, hey, this person's on Levofed, talk to the doc. The doc's like, okay, what do you know about Levofed? Is that okay? They can kind of run them through it and say, give them some parameters around like, here to here dosing, and talk about what the goal is. And we're not trying to fix people, we're just trying to get them from here to there, right? So, you need to be realistic about what you're trying to do and say like, yeah, they're on 5 levo, that's great. If the pressure goes down, turn it up to 10 max, call me back, get to the hospital, whatever, sort of simple things. Again, you are accepting a little more risk when you do things like that, but I think it's a start, and we're just all trying to fix kind of a fucked up system anyway. So, so that'll be interesting, and that's one of the reasons. That's a main reason why the ACP resource was just put in Port Alberni last week.
Oh,
so, yeah, they just started one. Right now, it's being staffed by randos, just kind of anybody they can find. We have a traveling paramedic program, it's called, which is sort of an in-house agency kind of idea, but basically people can submit availability and they'll like send them all around the province to plug holes. And so that's what they're doing here, is they're just inviting ACPs from around the province to come and fill this while they work on a temporary posting and try to fill it and everything like that. So, but the idea is to help offload some of that. Hey, this person is, like I said, like needs a monitor and 1 infusion and needs to get to Nanaimo. It's like, okay, the ACP, their job isn't just to hang out here and do calls. It's like, great, go do that and just zip them down. And we just talked about monitored calls and like how much CERT does calls that are just for cardiac monitoring. And it's like, that's kind of stupid a lot of the time. Like, we need to rethink that probably, because I don't know what your experience is, but nothing goes wrong with those transfers.
Not usually.
Not usually,
yeah.
right?
Well,
So,
and usually, they don't usually need the cardiac monitoring.
Mm-hmm.
Yeah.
Exactly, but I think it's one of those things where if you're a doc sitting on a ward, you just tick telemetry on an order set or something like that, not realizing that actually screws up the next 24 hours of this patient's journey just with the demands that puts on the system. So I don't know. We're trying to fix it, and I think eventually PCPs, there'll be monitors on every car, and we will upskill PCPs to that, which will be great. But I think that it's just millions of dollars to buy monitors. I'm actually going over next week to become a super user because we're trialing the new Zoll monitor on some ECP resources.
Oh, wow.
Yeah, the Zoll, it sounds like Xanax, but it isn't, which is weird. It's very similar name, but it's a new Zoll monitor that I'm trialing, so that's kind of fun.
We're supposed to get the 35 life hacks.
Oh yeah?
Yeah.
I think they're looking at that, but we're gonna try the Zolls as well, because Zoll went to, they have a knob on them now, like, that's what everyone likes about the Life Pack, is how, like, I like the Life Pack, it's very user-friendly.
Yeah.
The Zolls we have with flying have so many buttons on them, they're kind of annoying to use, but.
Changing the paper source.
Yeah, yep, and the way they print out is, yeah, I don't know. Yeah, so that's ACPs. Next is a critical care paramedic. So there's not many critical care paramedics. It's all in-house training in BC. And just so you know, like I've been talking a lot, we'll finish off this section and we're gonna take 5 and get a coffee. But it's all in-house training. So we take ACPs with their training, and they apply and they come into the CCP training with BCHS. It's about 2 years that you do in addition to the ACP training when you come in. And it includes the BCIT specialty nursing program. So we do all of the online work from the BCIT course. We obviously don't do like the clinical stuff, like we're doing our own clinical, but all of the, anyone's seen it who's done it, oxygen supply and demand framework, and then you get into this, and that's where I learned about things in a mesocontextual lens, and I'm like, I don't know what that is, because I'm a paramedic, and I'm like, okay, so I got through that course, but it's, we do that, which is actually really great coming from a paramedic, because it's the first time you get a lot of insight into hospital stuff and ICU care, which we don't know about as paramedics, right? So it's really helpful that that's included in there. So it's primarily intensivist taught. We're changing a little bit now that we have sort of a good cohort of experienced people now. Like our own instructors can teach a lot of the sort of like basic lectures and cardiac and other things where we don't need to have it. But we do have a lot of specialty physicians that work with us come in and teach, which is really great because you get a chance to sort of really dive into things and get a lot of like 8-hour one-on-one time with the ICU doc or something is pretty good, pretty cool training. So that's nice. And you focus a lot more on critical care, pathologies, and sepsis and trauma, and you just get deeper into a lot of different things. A lot of time on anesthesia planning in terms of like how to facilitate things, even from like just having to primarily RSI or mechanically vent somebody, and trauma care. And then the recent change in the last few years has been what happens is you do your core CCP training and you get your CCP license, but you're not operationally deployed yet. After you do that, that's just over a year, then you branch into either maternity, neonatal, or pediatric, which is what ITT is. They're just kind of rebranding it, or into the adult side. So if you go into the MNP side, you're doing more time at children's, you're doing like neonates, the baby box, like that sort of shit, which I couldn't care less about, so I don't want to speak to it. Or you go to the adult side, which you spend a lot more time on difficult ventilation strategies, lots more ultrasound training, and everything as we've introduced that. So when you do the CCP, you get a lot more, you have a lot more options available to you, which is great. And so the split generally for CCPs, because they do all the air response as well, is about 20% pre-hospital or like auto launch type of like scene calls, and then about 80% interfacility transfer. And that's around the province. A lot of it's by fixed wing that we end up doing, or by helicopter on the island. And especially with these new helicopters, they're a little bit faster, so we're doing a lot more moves by helicopter than we did previously, which makes for some really long helicopter rides, to be honest. So yeah, we just have we can kind of manage whatever we need to, moving people from ICU to ICU or whatever, so it's kind of nice. We have just, we're just introducing finger thoracostomy and chest tube placement as well into the CCP practice, so yeah, that should be coming in the spring. Escharotomies on there for like severe restrictive burns, which is like, I don't know how often that happens. I've literally done one in my whole career, and I wasn't even allowed to. I just did it like years ago when I was working on the street, and this guy came out looking like a sausage, like they'd have been on the barbecue, and it's like, he was still alive, but we couldn't ventilate him at all. So I'm like, I don't know, call the doc. I'm like, how do you do an escharotomy? He's like, are you serious? I'm like, dude, just tell me right now. So Anyways, he died. But it's but
Because of the escrotomy?
I don't think so. I like to
Good
think
talk.
I like to think it was probably the complete lack of oxygen and giant cyanide dosing from plastics or whatever. But so there's a lot of stuff in there. There's a lot of stuff in here that we do have that I like. I mean, everybody has their own feelings. Like we actually have EEG monitoring, like frontal, what do they call it? BIS, like bispectral EEG monitoring for sedation levels and stuff like that, which kind of came out of an era where we were doing a lot of psychiatric transports by air. And there's been a few adverse events in the air, like people going wiggy-whack and trying to get to the pilots and fights on and this sort of stuff. And so how sedate is somebody? It's like, well, let's actually measure it then. So that's that came up. But realistically, nobody actually uses it, even though there might be evidence for, minimizing sedation, like all those things, because people don't need to be at a RASA -5 all the time. Like, can we lighten their sedation? Which is lovely, and maybe that's relevant in a long transfer. But really, if you're going from here to Vic, it's like, let's just get the job done. Like, they can worry about the sedation level and all that later, and all that fancy stuff. But a lot of mech vent. We spend a lot of time talking about mechanical ventilation for different pathologies, because you can, and RSI and anesthesia planning, because you guys have probably seen it in your careers where it's like somebody sick comes in, and then you intubate them, and then 5 minutes later they arrest, and everyone goes, oh, they were really sick. I'm like, they were, but you killed them. Because in the end, we didn't account for really good resuscitation or like the actual physiology of what's going on with their trauma or their heart failure, their right ventricular disease or whatever. So it's something we try to get into a lot. I wouldn't say we're perfect at it, but we try to be a lot more aware of these things. And we're all very good looking. So common equipment. Maybe what we'll do here is, this might be a good time to just sort of talk about it, and I'll just see if an ambulance is here. If not, I'll just call and maybe see if somebody will tootle up, because I'd like to go and paw through the ambulance and actually take a look at what's available and what's in there. Does that work for you guys? Mm-hmm. So why don't we take 5, and I'll just sort of see who's around, and we'll just sort of organize that. Cool, so yeah, come on in.
We can share this.
Lots of room. You can fit lots of people in these things. Yeah, a little chair there. Yeah. Cool. Seatbelts on all the chairs, just so everyone knows. So have you guys done a lot of transfers? A few? Yeah.
I have not done one in a long time, and I've only done like a couple.
We're going to talk a lot about like what goes into the transfer, but just from a purely like physical sense, I think it's just really good to know certain things. Like where do you guys as the nurse jumping in a car usually sit? There, right? I think that's pretty common. I think that's what most people probably do. Usually the paramedic will be sitting here. So because usually monitor there, maybe IV pumps on the pole or whatever, you've got a bit of your own setup, but like that just sort of makes intuitive sense. But I just want you guys to know what's in here and what isn't, so that you know, like, if shit goes wrong, like, what do we need to know? This is definitely the most important area, right? In terms of having all of your airway stuff up here, and it should be pretty nicely labeled. There's going to be OPAs, there's going to be nasopharyngeal airways, pediatric supplies, pediatric BVM, neonate BVM. There's going to be some PPE stuff up here, and then there's going to be adult BVMs, as well as cannulas, different masks, and then the MDI and stuff for aero chambers, and then of course, importantly, suction you need, and oxygen, and there'll also be an oxygen at the back. And then, of course, like anyone, you can just, like, they're just the same. You can unscrew it here if you need to put a high pressure hose on for a ventilator or something like that. Down under here, you'll have a bit more suction tubing and just sort of some backup stuff, as well as usually our CPAP. I'm not going to open their CPAP just because they might need it, but I'll grab one out of my little car later when we're talking about it. And then they keep little maternity kits. They come pre-packaged, so just in case you're ever in that unfortunate situation, we do have maternity kits that come with nicely packaged up here with a bunch of towels, umbilical clamps, scissors, and a little suction catheter, and a little baby hoodie, like their little baby cap, that sort of stuff. But this is the important part, and we'll get into talking about how we do those transfers and the sort of the roles. I really want to talk about that. As you go further back, you get into so here's eye gels. If you actually needed to, use sort of more of that advanced airway kind of thing, and which is maybe I'll grab some of those as well, so you guys can actually, if you haven't handled them, like actually sort of see what they are, and we can talk about how they actually work and what they're good at and what they're not. Because you sort of know, like, oh, there's an eye gel.
but when's the last time you actually looked at one and thought about it and went through it, right? So that's not a bad idea. Sort of some first aid-y sort of stuff. Here's where all of your gauze, cling gauze, trauma stuff. We do have like chest seals for trauma, like one with one-way valves built into them, which are really nice and expensive. Splints, all that sort of stuff is up here. And then in the back, there'll be IV start stuff. So there'll always be, we really only do 18, 20s, and 22s for sizing, because there's no point in really doing much else. PCPs, hey, PCPs can only do over 12. They can't do pediatric IVs. It's out of their scope. So that's something they won't be doing. And then you'll have saline up there, as well as D10 and admin sets, and then some various syringes, as well as the drugs that I sort of mentioned are in scope for PCPs will all be found up there. There's also nitro, which I forgot to mention, and aspirin, of course. I mean, that's just pretty basic, but those things are all available.
For the IOs, what's the scope for those? PCPs as well, or?
Yeah, so IOs is a bit of a funny one. So
Yeah.
PCPs, it is in scope for PCPs, but in a very limited setting, because there was a general fear in the service and in leadership that it's like you can't just Wild West it with people putting IOs in people, because it would be about 3 minutes before somebody started an IO to give somebody 12.5 of gravel. You're like, no, man, that's not what we're doing. But so it's really just for cardiac arrest, where hypovolemia is a likely indication. And a lot of this came out of the heat dome. And that's sort of where that kind of push came from. You'll eventually probably see that change, like most things do. It is in the scope now. There's some other stuff that's technically in their scope, but not operationally in their scope, like needle thoracentesis for tension in the thorax is technically in PCP scope, but we don't operationalize that right now. But I think you'll eventually see that change as well, especially in the setting of a traumatic arrest, where you get to a point where it's like, well, they're dead, so like, why not? But for live people, that's where people get a little more sticky on it. So the other time that PCBs can do IOs is if they're with an ACP or higher, you can task them with it. So yeah.
As a nurse, would we be able to task them with it?
No, it's very specific to. It needs to be an on-site ACP. It can't be a proxy. Yeah. So good question though. But no, I've been on a lot of calls where things just you're busy and shit just happens the way it has to happen, and I think we kind of understand that. But realistically, it would be putting them at risk to do that. So I think that would be an unfair ask. Is how I would put it. So that's kind of the inside. The stretcher, obviously, these things are, we'll pull this one out and just sort of play with it, but they're all hydraulic and fancy, which is great because they lift a lot of weight. This has dropped our back and our injury rate huge since these things came in. You'll also see there's some drawers down here. If you open those up, there'll be some IV supplies, there'll be a glucometer, there'll be a thermometer probably, there'll be two, and there's one down there that might be the IV stuff. Yeah, so just easy access to start an IV or grab a flush or something, usually right there. Temperature controls and lights, and some gloves up above you as well. This is a pediatric kit that they carry, so this is all of this stuff in here. There's an access from the outside as well. This is the stuff that we take in to calls. So this is where the AED and the portable suction will be. So if you had a problem, there'll be a portable suction, and then as well there'll be their kit, and this is sort of their main. It's not meant to come this way. Their main kit that goes in on a call. And this is kind of what they go into a call with. So there's going to be a blood pressure cuff, an SpO2 monitor, IV supplies, BVM, airway, IVs, trauma, and then some medications here. So that's all the stuff you bring into the house. So that's, again, it's just a duplicate. So, if you run out of stuff, it's like, oh man, we're out of 20s. It's like, okay, there's probably more in here, whatever you might need. So, and then, also worth just laying eyes on the portable suction. So these are just a portable suction that we have. They are adjustable. There's a little silly knob down here if you need to do it. So maybe relevant if you have a pleurovac or something, right? If you need it to suction, and they can help you set it all up, but it'll just be up to you to sort of look and see if it's kind of Mickey Mouse. But I assume you can set the suction to something. But
is it battery operated? Or?
Yeah, these are battery. They're usually plugged in. They should be charged and fine. This one will just keep running. as well. So I would sort of default to this one if you need it. This one, but sometimes you need two. You're dealing with airway shit and you have a pleurovac, so you need two suctions. So yeah, so that's available if needed as well. And then while we don't have monitors on every car, something that is a big bone of contention amongst most PCPs and everything as well, there is going to be so there'll always be an AED there as well. So yeah, so there's all the airway stuff, there's AED, there's kind of all the resuscitation gear. Yeah, like this is pediatric stuff. We won't even open that up because we'll just hope that never happens, right? Just hope and prayer. And then there's tons of oxygen. Now, something to be said is like if you're running somebody with a vent and high FiO2 and you're doing, it's like, you know, you can run out of oxygen on a big call. So it can be worth sort of looking and saying like, hey, you know, just asking like how much oxygen do we have? Should be tons. There's 2 giant tanks in here, so yeah, there should be lots of oxygen. I think that's about it. Kind of. Any questions on this stuff?
Can I say a few things?
Yeah, please do.
So just to elaborate on the oxygen thing, when you do phone in to PTN, you can ask for the ambulance crew to check their oxygen level. There is some apps that I'm sure you can well versed in. You can tell us later to help you also determine how much oxygen you're going to need. I have had ambulance before that were delayed because they had to go fill up their tanks. So something to really consider, because you don't want to run out of oxygen on the way to wherever you're going. You have 2 plugs, is that correct? Only 2 plugs. So just thinking about that when you're going to have to plug in things, if you're running any kind of infusions and you're using the cardiac monitor, you only have 2 plugs. So making sure that your IV pumps are charged and your life pack is potentially charged, because you're only going to have 2 plugs if you have more than that. And sometimes bringing in a backup, say you're running like Evo or something like that, bringing a backup pump is a good idea, just in case. If it's something that you can just free line in, like normal saline or whatever, not a big deal. But if it's an intricate infusion like that, it's always good to have. And making sure, sorry, got my hand in the way.
It's okay.
And also making sure that everything is tied down really well. Anything that's not tied down is a huge projectile if anything happens on the road. Not lots, you can probably speak to it better than I could about how many individuals have been injured or consequently have been killed because of flying objects. Whenever there's been an accident or anything, you want to think about limiting your time out of your seatbelt, because that's a risk for you and everybody in the back too. So thinking about where you're going to place things so you can reach them, that kind of thing. There was one more thing I was going to talk about too. And then always making a game plan with your crew. So
we're going to get into
yeah, perfect.
Yeah.
I kind of figured you would,
Yeah,
so I didn't want to step on any
human
toes.
factors and stuff afterwards as well.
Yeah, cool. I think that's the main things.
Cool. So, any questions? I mean, that's kind of it. It's
Makes sense.
yeah, and well, then we'll talk a bit more about the crew and the interoperability and everything. So, yeah, groovy.
Yeah.
Cool. All right, let's do it.